Perfect. Um, so welcome everybody. Thanks so much for signing in today and this afternoon. Hopefully we can have a nice educational thing for you here. We will record this, so this webinar will be able to be posted like as have we've had our other webinars that have been able to be posted online. You can view them, stop, rewind, listen again, view it again. That's the nice part about it, is as opposed to like even just being in office or in a conference, you can't really keep a track of those kind of things. So this you can go backward and forward, and you don't have to feel like you memorize everything I'm saying about today, because we will post that. So that's one of the nice benefits of that. Second, I've done a few of these different webinars for different areas, and probably a nice talk there, or a segue, is that we've talked about these branding things. So we are the Cleveland Orthopedic and Spine Institute, which means that we cover a lot of different areas: shoulders, hips, knees, spine, pain, foot and ankle procedures. I believe
Dr. Callahan, your sound went down.
Oh, it went down?
Yeah, we couldn't hear you.
Okay, I'm unmuted.
There you are. There you go.
Got me? Okay.
Yeah, that's good.
Okay. Yeah. Thanks, Kelly. Yeah. Please stop me if there's any technical stuff, or I have my phone right next to me in case there's any other issues. So at either rate, what I was saying essentially is that we have different orthopedic areas that we cover. And so, I am the director and founder of the Cleveland Hip and Knee Institute. I am trained across all manner of orthopedic surgeries. I do perform everything from shoulder replacements to hip and knee replacements to I do general orthopedic, carpal tunnels, trigger fingers, the hand conditions and wrist conditions that we're talking about today. And then, also knee arthroscopy, ACL procedures, those sort of things. So we can cover a whole gamut of things. So don't let just one specific brand drive you into thinking that's the only thing we do. We're not one-trick ponies here. We can definitely take care of a manner of area, and we're very well trained in subspecialty areas as well with focus. So it's kind of a nice blend of everything. So with that, I wanted to make sure that I covered some common topics that I see in my clinic and that I take care of, and let you know a little bit about it or teach you a little bit about it. So today we're talking about common hand and wrist problems. So disclosures first, just I have some educational support that I've received from a couple of companies. It's not related to this specific talk. However, they have provided some educational content and support. So I just recognize that. Disclaimer wise is really important. As I mentioned earlier, this is a generalized overview of these concepts. This is not an individual consultation, and that's important because those personal questions that you definitely are going to have, and if you're logging into this webinar, you may find that one of these things is exactly what's bothering you, or something that sounds really similar. As much as I'd love to discuss those things, the best place and the most appropriate place is to do that in an office consultation. That's the safest and most important area, because we can have a very personalized discussion and evaluation of that. Certainly the question and answer section, I'm able to answer generalized questions. But please feel free to call us, schedule an appointment, and we're happy to meet with you and talk to you about what's bothering you and see what we can do to help you out. So in general, I'm from Northeast Ohio. I was born and raised here. Went to school over in Cleveland at Baldwin Wallace, and then did my medical training in Western Pennsylvania, including an adult reconstruction fellowship with hip and knee procedures. But I've continued to practice general orthopedics as well, accompanying that, and so that's why we're talking about these hand and wrist type problems. I frequently have patients come in after a hip or a knee or a shoulder replacement, and they describe something that's bothering them too, and then, hey, do you know anybody? And I said, yeah, I can treat that for you, no problem. So it's kind of what spawned this lecture. So one of my patients in particular, actually, example, was a patient that had a successful knee replacement procedure, and she came back in and she was having a lot of pain in her finger, and she kept locking on her, and she was just saying how troubling it was, and it was catching on things, and it was just really bothering her. And she's like, "Do you know anybody that can help you?" And I said, "Well, I can." So we'll talk a little bit more about what specifically was bothering her, and discuss that condition, but just something to kind of lead us into our discussion today. So first, we're just going to cover some basic concepts with hand and wrist anatomy. Next, we're going to hit some of these high yield topics, or high frequency topics that I see in my clinic. Patients with carpal tunnel syndrome, what is that? What do we do with that? Trigger fingers, wrist tendonitis, and then thumb arthritis and pain. That is, those are probably the most common things that I see in my clinic. So overall, the hand and wrist anatomy is wonderfully complex. Something that has been adapted over time and has started from things that were less complex and has gradually grown to a more complicated thing. And so over time, as you'd imagine, that as our hand has adapted to our needs to use, that can present problems with it. And so there are things that, because it's so complex, it can have complex issues. It leads itself to also issues with problems of common usage, repetitive usage. So overall, this wonderfully complex structure can have some issues that come up from time to time, and they can be simple or complex. So to review our hand, you kind of start off with the skeleton or the bones within the hand that give the support and structure for the hand to function, for the ligaments and the tendons and other tissues around it to give it support. The hand has kind of three sections of bones that you can think about it as: the finger parts, which include the metacarpal bones, which are more into the palm of the hand and and near the base of the thumb, and then the finger bones that go extend up into each digit in particular. Then there's a section in the middle, which is the wrist bones, which is a complex structure of several bones that create a transition zone from the fingers into the forearm. And it allows for complex motions and manipulation and allows you to do very, very fine motor and branching over into motions that aren't just a hinge type joint where you bend or straighten or move side to side, tilt side to side. It can kind of rotate, move, slide, and perform and allow you to grasp certain objects in certain directions and manipulate things, because again, our hands are super complicated, so they can allow us to do all these different tests. So that's the wrist bones, is this middle section, and then the forearm bones that most people have usually heard of. They're called the radius and the ulna bone, and that forms up the wrist and hand as far as from the bony structures. The other part of the hand anatomy, there will not be a test at the end of this, so you don't have to memorize any of these things. But essentially, there's these wonderful tendons on both sides of the hand, on the palm side and on the back side, that help you move your fingers. And those tendons, and they come and start all the way up at the forearm, and they extend down into the hand. And then there are several muscles that start in the hand, and they go to each finger, and they all perform a specific function. And each one of those sites can obviously be a source that could cause a pain or cause tendonitis. So understanding that there's these different structures that exist in the hand and the soft tissues of the hand helps you to understand why you could have pain in one part of the hand, and even just a few millimeters of difference could mean a totally different structure that's causing that discomfort. So another specific area in the hand that is very, very high frequency that we see of trouble in the hand, it's just the way that we're built. You have this section of the wrist and hand that's called the carpal tunnel. And so those bones in the wrist make the base of that carpal tunnel. And that you can see here in the cross section of the hand. So this is the palm side, and now you can see the fingertips. And then you're looking through this section. There's a base of that carpal tunnel is the bones of the wrist. And then the tendons that help you move your finger travel through this. So they start at the forearm with the muscles, and then they pass and they turn into tendons in the forearm, on the front side of your forearm. And then they go through this canal. And once they go through this tunnel or canal, they branch off past that point and go to each individual finger and thumb and help to move those structures. On the top of that is a ligament that's called the transcarpal ligament, and that ligament helps to keep those tendons in the space. Within that space, there's a nerve that lives in that space, and that can, over time, can get compressed and cause symptoms. So that kind of leads us to our first major condition that we see, which is when people come in and they'll start describing pain in their hand or in their wrist. Sometimes it's tingling, but frequently there's some type of nagging, prolonged issue that may be constant or may be related to certain activities. Frequently wakes people up at night, and that's called carpal tunnel syndrome. Pain that's within the hand and wrist. Usually, it's on the palm side of the hand, but it can extend through the wrist and up into the forearm. And I've even had patients that have described pain that goes from their hand back up towards the shoulder. And so and actually, after treating them, that pain that went up towards their shoulder actually resolved or went away, which was actually pretty impressive. So the tingling and numbness tends to be, for carpal tunnel syndrome, isolated over into the thumb and index finger side of the hand. It extends into the middle finger or the long finger of your hand, and sometimes it'll touch a little bit of the ring finger in the hand. But usually people will describe numbness, and they don't get usually that specific. They'll just say, my hand keeps going numb. It wakes me up at nighttime. Sometimes I have to shake my hand out in order for that feeling to go away. And I've been noticing it's getting worse and worse over time. You may have difficulty with grabbing things, opening jars, pain with that, or just weakness in general, or trying to manipulate certain objects, or even like holding the phone might be more difficult, and trying to do that, and texting, those types of functions, those can be more challenging. So again, we're seeing that anatomy again, that slice. You can see that those tendons that help to bring your fingers through, they're very firm and they don't have a lot of give to them. And so repetitive motions, every one of those tendons with repetitive motion can get a little bit inflamed. There's a lining around each tendon that provides it nutrition and allows it to glide through a space without getting a lot of friction. Well, that can get inflamed. And because they're so firm, they don't give. So the space in there with those bones, which do not give, and the ligament, which does not give, kind of creates a constricted space. So if you get swelling into there, it can squish other things in there. Well, the other thing that happens to live there is a nerve called the median nerve. And that gives you the sensation on that part of your hand with the thumb, the index finger, and the long finger or the middle finger. And that you get that classic kind of feeling, especially if you put your hand in a position where it's bent forward. You can get that pinching of the nerve. And we can assess that in an office. So when I look at it, patients with that, I can press over that area or hold your wrist in a position, and those fingers can get numb or get worse with their numbness in the hand. And that's called carpal tunnel syndrome. So you can diagnose that, again, like I said, in an office visit. You can also assess for this on a nerve conduction test or an EMG, which is a special test that's done usually in a neurology office or in a neurology center. And what they use is these special electrodes, and they test the nerve and how long it takes for the signal to go through. So nerves are like sort of like electrical cables that go down from your brain, spinal cord, and then into each portion of your body. And they either tell the muscles to contract so you can move something like your hand or your fingers, or it's telling something about where that position of that muscle is or the sensation. So if you touch something, the nerve goes from your hand up to the spinal cord to your brain, and that communicates, oh, I'm feeling something's cold, or something, I'm pressing something in between my fingers. And so when those nerve cables, when they are getting pinched, like in carpal tunnel syndrome, and that space is getting pinched, you don't that signal doesn't get through as well. So it's like static through that signal. So I think of it like it's almost like the sparky cable, and it's just getting smushed, and it just doesn't want to send the signal through there that well. And so when that happens, you can get more weakness, those symptoms of that numbness and tingling in the hand, or weakness in the muscles that nerve, specifically the median nerve, what that goes to. And there's a thumb muscle right here in the palm that the nerve gives a sensation and gives the function to. If that's getting pressed, that muscle is not going to work as well. So you'll start to notice those symptoms. So once we kind of diagnose the carpal tunnel syndrome, we can begin treatment. The reason that I get an EMG and nerve conduction test in an overwhelming number of patients is to assess how bad the disease is. You don't necessarily have to have the test in order to diagnose carpal tunnel syndrome, because it is a syndrome of that numbness and tingling and weakness, and then the signs when I examine people. But it can be identified on the nerve conduction test, and why I use it is to understand how much that nerve is getting compressed and how significant the disease is. It gives me information for, if it's very severe, how long it will take to recover, or it gives a guide to whether that nerve can recover or not. So great. What do you do when that happens? If you've diagnosed carpal tunnel syndrome, what can I do about it? Well, non-surgically, there's braces that you can wear to help support the wrist and take the repetitive strain out of the tendons, which will help to maybe allow the tendons to decrease their swelling and decrease the amount of compression on that nerve. There is an injection that can be performed in the office. We can do that with ultrasound guidance and place it into that carpal tunnel to help decrease the inflammation that's in that space. The difficulty with carpal tunnel syndrome is that it tends to stay. It does not usually get too much better. The symptoms may come and go, but they generally tends to either stay the same or get worse over time. And when there's significant enough compression of the nerve, that's a danger that it could become a permanent damage to the nerve. The nerves are very sensitive, and they do not tolerate being crushed over long periods of time. So when that happens, we can pursue a surgical treatment where we help to release that ligament, and that's called an open or endoscopic release of the carpal tunnel. So for the example on the left shows an open carpal tunnel incision where it's located. What you do is you make a cut in line with the skin directly over that ligament, and then release the ligament by looking directly at it. To the right picture is a depiction of an endoscopic carpal tunnel release, where you go underneath the ligament, you make a small incision in the wrist, and it's below or before the actual, it's not right into the palm, it's right at the wrist crease, and then go underneath the ligament with a special camera and scope equipment, and then this releases the ligament from underneath. So the release from underneath, and why I like using that endoscopic type technique, which is my preferred technique, is that it allows for a faster recovery. So when you have an open incision, you can release the ligament just fine, but the problem is it's right in your palm of your hand. So if you grasp something really hard, you could split the incision open. They tend to heal just fine, but it takes a little bit longer for the recovery time frame for that. For the endoscopic carpal tunnel release, you can use your hand immediately after the surgery. Allow patients, as long as they feel comfortable to do so, they may return to pretty much every activity that they wish, understanding that we did release the ligament. So there will be some discomfort from the release of the ligament. So I kind of describe it like how if you've ever sprained an ankle, you know that over time that ligament will heal. You just need to support it for a while. But for the wrist, there's no need to immobilize it any significant amount, just to your comfort level. But I've had patients that I've done surgery on. We keep a dressing on for a few days to help out with the swelling from the surgery, and they go back to work on they do it on like a Friday, they go back to work on a Monday. So it can be a very fast recovery, and that's including even manual labor jobs, type jobs. You just protect the skin incision with a simple Band-Aid. So it obviously makes the recovery a lot faster for that type of a procedure. The other way I like to describe this is sort of like this carpal tunnel disease is you got a compression of the nerve. It's sort of like Thanksgiving. And so you eat a bunch of food during Thanksgiving, and you get that belly sticking out a little bit. And so that's sort of like the canal or the tunnel here. And when you release the ligament, that nerve gets a little breathing room. It's like popping that button on top or releasing that belt, and just, the nerve just relaxes. And so I kind of almost think about that when I'm doing the surgery. I just like, man, that nerve really has to appreciate that. Now it has all that extra space. So another common condition to move on and talk about is a patient that comes into my office. A very common complaint is when their finger is catching, it's locking. You know, another thing that wakes somebody up at night, the finger gets caught in a certain position and it just causes a significant amount of pain and discomfort. And that's called a trigger finger. Here's a great video demonstrating an active triggering finger. So you'll see this gentleman who bends his hand and his wrist, and as he goes to straighten out his fingers, one finger gets stuck in a trigger position, like if you're trying to pull a trigger on a gun. It gets caught in that position, and then you have to manually force it away from that position. That trigger finger is a phenomenon. It's part of our wonderfully complex anatomy of our hand. Is that when your tendons go down into your finger, they come all the way from your forearm, and those tendons help to move those fingers. They're attached at the tips of your fingers. So when your muscle contracts in your forearm, if you just sit there now, you could actually move your fingers. If you put your hand on your forearm, you can actually feel the motion and the squeezing and the bulging of the muscle in your forearm, where those tendons that are moving your fingers are coming from in the forearm. And so as you do that, you can see how you can track that down, that motion down your forearm, and feel it go through that carpal tunnel we just talked about, and it branches to each finger. And so if were just connected at the tips of your finger and at the forearm, and there was no tissue in between there holding those tendons in position, then it would do a thing called bowstringing, where as you bend your fingers, the tendons would pop out like this, right under the skin. And as you know, with any type of moving something or using if you're trying to lift something, that something that can help out is a pulley. And so what our body has adapted and has created are these little pulleys that are made out of soft tissue, and they hold the tendon down towards the bone. And so that allows that tendon to sit down close to the bone, and it covers that tendon just enough to allow for motion through that space. So it's traveling through a tunnel and it's sliding back and forth, and that pulley allows that to lever against that to increase the amount of force you can get, or to be able to squeeze or grasp something, and it improves the motion of that tendon to allow for that. Well, you have just enough room through these pulleys to allow for the motion of that tendon. So if anything comes in that causes more inflammation in the hand, in the tendons, maybe an injury, or just using it over time, it can build up to a point where there's not enough space for that tendon to run through that pulley. So it starts to cause friction, and friction is painful, and it can start to cause a nodule, or kind of like a thickening of the tendon that develops over time. Well, now that thickening of that tendon is trying to pass through the same space that it's supposed to, this pulley. And so it's sort of like this tunnel that you have to force this rock through, and it can't get through, or once it does, it gets stuck on the other side. So it forms almost like a finger trap. And so it stops it as it's trying to pull back. And that's what you're seeing on that video. And so the way I think of it is like you're driving that truck and you see that overhead clearance sign, and you don't have enough clearance to get through. What's going to happen? Well, obviously it's going to stop. It's not going to allow it. Okay. And so you can see, as this gentleman, I'll play the video one more time. As he's bending his fingers, the tendon is forced through, and that nodule goes through that space. Once it gets to the other side of that pulley, it sticks the finger in that position and locks it. Then with manual pressure, he can push. He can overcome the force he needs to get that nodule through there and pull back through and slide through. But it forces that finger in that stuck position past that point. And you can see it release and go. So obviously you can tell that's a very uncomfortable thing to have. And so what happens when you do that? Well, this is actually my same patient that came into me after a knee replacement, was talking about her hand hurting really badly. And I examined her, found that she had the trigger finger. So we tried a corticosteroid injection or a steroid injection into that space to try to decrease the swelling that was happening, because it was kind of a newer phenomenon. It's something that had been bothering for a very short amount of time. A lot of people can get relief from that. it's somewhere between 60 to 70% of patients can get some significant relief with those corticosteroid injections, and that can solve the problem and allow that to go away. Other patients, it can last for a while and then come back. I generally find that people who have that triggering where it actually gets locked in the position and they have to manually take another finger and push it open, or they have to really force it to do it, like that video, um, those ones tend to be less successful with just the steroid injection or the anti-inflammatory injection. That's what a steroid is. So what you'll have to do at that point is to surgically release that pulley or that band that's holding down that tendon at that location. And so that's what we ended up doing. We tried the injection, lasted a couple months, then it came back. So we talked about doing the surgical release. We make a small incision over that area of the hand where that ligament, or the pulley is located. And so once you make that incision through that pulley, it releases that. Don't worry, you have several other pulleys in the finger, so you don't lose that grip strength or that power through that digit. This is the most common location, is in the palm there. It's located, or on this diagram, it's called the A1 pulley. That's the most common one. But either way, that once you release that, it causes almost everybody notices an immediate relief from that. They're able to bend and straighten their finger. I make sure of it during the procedure. It's under local, meaning that we just numb the area, and then we were able to perform the release. And the patient can immediately feel that their finger is no longer triggering. Some of the swelling takes a little while for it to go away over time, but most people have a significant amount of relief, and that's an outpatient type procedure with local numbing medicine that can be done. Moving on to some causes of wrist and thumb pain with grasping or trying to lift something up. That's another common reason people come in. There's a couple reasons that we can have that kind of pain through the wrist and thumb area. The wrist in particular has a condition. Again, you have those areas of the hand that have different soft tissue bands across them. Anywhere you have a tendon in the hand, there's usually some type of attachment around there that could, at several points, to help it to function better. Well, that area where it's constricted, or where there's a band, can develop inflammation in it, and that can cause tendonitis, which then can cause it to get caught, just like that truck trying to go through the tunnel. It can get caught through that point. And so one common area over the thumb, or the thumb side of the wrist, to have pain is what's called de Quervain's tendinosynovitis, or tendonitis. That's just a fancy term for the tendonitis in the wrist on that thumb side. So there's a specific space there that's very, very common for that to happen. This can occur in several different spaces, but this is probably the most common. Most patients that develop this have that repetitive lifting type either job or activity that they're doing. Certainly can see this with cell phone usage. That's certainly helping to bring more patients in for problems related to their thumb and wrist. Holding the phone in that position for long periods, or like this, and looking at the phone you can develop tendonitis through that wrist. As this picture is depicting that a doctor who's holding the wrist in this position. This is a classic maneuver to make that tendon have to slide through that space where it's pinched. And what happens is you have pain on that side of the wrist when you bend the hand into this position. And that's a classic sign for that. And it can be very, very uncomfortable, and you can feel it sometimes clicks or causes a burning type discomfort over that side of the wrist. And sometimes you'll feel or audibly hear a click when it's really severe. And so here's an example of those tendon sheaths that are those little bands of tissue that help to organize these tendons that are going across the wrist and from the forearm and into the fingers. And these little areas are called compartments. And those compartments can get that constriction. And you'll see that those tendons have lining around it, and they get caught in that compartment. It can rub against there. And so then when you go in and you have that trouble, you can wear a brace You can try injections in those areas. A thumb brace for particularly the thumb when it gets caught in that space in this specific condition can be effective. Another time, again, the injections. Physical therapy is another way that you can help to help relieve discomfort, strengthen the muscles around the forearm, and provide flexibility. When none of those things are working, or if it's significant enough that you can hear the click and feel this significant pain over that side of the wrist, you could perform a surgical release of that band. Again, this can be done under a local numbing medicine, outpatient type procedure. There's a small area we just have to protect the skin. But you can, generally to your comfort, to resume most activities after a few days to allow for the surgical swelling to go down. And then once the skin is healed, you can resume your activities as tolerated. That one is a very successful procedure too, like the trigger finger. I'd say most patients are able to go back to whatever they want to do within the next couple weeks after the surgery. And it's, again, very, very definitive type thing that very helps out a lot for patients. Another area that's very common, probably one of the most common things I see in patients is basilar thumb arthritis, which is just a fancy term for the bottom part of your thumb where it meets up with the wrist bones. You get arthritis in here. So this is where we're talking about that wonderfully complex anatomy of the hand that we've developed over time. Because we have the ability to have what's called an opposable thumb, which is to grasp objects, it's not in the same plane as the fingers. So as you bend your fingers, you can tell that the thumb obviously is not in that same plane. It can function in this way and bend and straighten down. It can also open up in this plane, and then it can also move in this plane. So that ability to have that motion that can circulate around and in any different way in a pose and grab fingers allows us to grasp an object. Well, the price of that is that we have developed over time the ability to have that function, or that what's called opposition, or to bend that way, to grab something or to manipulate something in that way. Well, in order to be able to have that function, there has to be a joint that can make that happen. That joint that can make that happen is at the base of the thumb. And that base of the thumb joint, because it's in a position like that, it puts a lot of stress through that part of the thumb. So as you pinch or grasp something, especially forcefully, whatever the amount of force you can generate through the thumb, there's various studies that talk about this, but it can be up to 7 times the pressure that you can put through here can go through this thumb and the base of the thumb here. So whatever, you can imagine how hard you can pinch something. You can put 7 times that pressure through this joint. That's a lot of force. And so over time, that joint really can't really bear that level of pressure. And you can start to get wear of the cartilage in that joint. So this bone in particular, at the base here of your thumb, it's called the trapezium. And that trapezial bone is one that has the ability to form arthritis pretty quickly. And you can lose the cartilage that's between these two bones of the thumb and that wrist bone, the trapezium. And so over time, when that develops and gets more and more painful, you'll notice some more prominence, or people will have a bump at that base of their thumb that kind of juts or sticks out a little bit more. And it's very uncomfortable through that section, especially if you try to grasp something really hard or pinch something really hard. You may even lose strength in being able to do that. So what happens when you have that? Well, we can try selective injections. There are wrist braces that can be helpful for that. Some physical therapy to help strengthen the hand. It's pretty remarkable how much a steroid injection works into that location. I've had patients that have terrible, terrible x-rays, and we treat them with injections, and they have remarkable results to the point where they have no significant discomfort, and they just continue getting those injections over time, and they're happy with that. And while that doesn't make a lot of sense to me, I'm happy to continue treating somebody without having to do a surgery if they get that amazing results. Now, that's not everybody, but certainly it is one that is always remarkable to me how much people can respond well to those injections. When that is no longer working, then there are a few different procedures that can be done. to address that arthritis in the thumb. But every single one of those surgical type procedures to help out with that thumb arthritis involves removing that bone, that trapezial bone or trapezium specifically, that gets removed from that part of the hand. So you just take the arthritis out by taking that bone out. And then what you do on the other side of that, there's a few different techniques to address that and to fix this bone, the thumb bone here, to the other finger bone. And there's a few different techniques that can go on we could discuss that in our office consultation of what technique is best, but there are several different ways to accomplish that, and all of them tend to do very, very well. And patients that come in after having that procedure are usually able to start getting back to their activities within a few months after the surgery. And they're usually very, very happy with the results for pain relief from that type of procedure. So those are kind of the major areas. I know I kind of went through that. Hopefully that was helpful for you guys. But in general, I just want to let you know that there's plenty of things that we can treat. I have areas coming all the way down to the fingers, to the toes, shoulders, wrists, elbows, hands, knees. I have colleagues that treat those conditions, spine, pain management. But I just want you to know that my personal mission, and it is the mission of my partners and colleagues, to give you excellent care, compassionate care. We want to improve your quality of life. We want you to get back to doing what you love. That's what our main mission and purpose is and our goals. And that doesn't always mean surgery. Frequently, and probably the majority of the time across our practices, that we try to treat people conservatively or without surgery. So my techniques when it relates to surgery, when that is a patient that needs that, is to try to respect the anatomy that's there, to use minimally invasive techniques, and I try to have rapid recovery with my surgery, so to get people back to doing what they love faster. So that's like the endoscopic carpal tunnel releases. For my joint replacement techniques, reverse shoulder arthroplasty or replacement of the shoulder, kinematic total knee replacement, partial knee replacement when appropriate, and anterior hip replacement surgery with a bikini incision and minimally invasive techniques. I have several webinars already addressing all of these techniques that I do as well, that you can go on my website to view, and along with this one, once we publish that. We also use a service and platform called Genie Health and PT Genie. This platform is pretty awesome, and every time I have patients come back, they give some pretty good feedback on how things are improved, and I know we're always working to get that better. And I gotta say, it's pretty remarkable the amount of results that we get from this platform. I also have a webinar about this one too. Starting to sound like I have podcasts for everything, but yeah, we have these webinars for everything. But this it goes through kind of what we do with this. Really great handheld thing you can have on your smartphone. We have it tied with physical therapists. You can come into our office and also get classic traditional in-person physical therapy, but it's kind of a great additional thing that we offer at our institute. Here's a picture of our new building where we're located and our address. And has been through this whole section. We have that section to call in for an appointment if you wish, or any other questions that you have. So now I will open up the floor for some questions that you may have. Obviously, Kelly, we have the typed in questions. That's what we preferred way to address those questions. Do we have any questions that you know?
Yeah, I just typed a sample. If anyone wants to, just in the lower right under more is where I see the chat. You might have to click there to get the chat to pop up. But if you have a question, just go to the bottom of your screen, hover over more. Actually, you might have to click more and the chat option will be there. So yeah, so I'm curious. I have a question. So the scrolling on your phone, so that's tendonitis. That's not carpal tunnel. I always thought that was carpal tunnel, but it's tendonitis when you suffer from that burning pain from scrolling on your phone.
Mm-hmm. Yeah,
Oh wow. Okay.
There's a few reasons. So nerve compression can sometimes cause those kind of burning discomfort, but a
Yeah.
lot of times it can be tendonitis that can cause that discomfort. And that section of your thumb is just absolutely classic. New mothers, that's when you see it too, very commonly. New mothers or a new baby that's there, that's born. Uh, the reason that they get tendonitis, and especially that jocular veins or the wrist tendonitis at the where the thumb is because they keep picking up the baby and holding it. And so over time, the baby gets heavier, and they keep picking it up, picking it up. It's that repetitive motion of lifting up the baby and the thumb in that position that bends it like that. So holding a
Yeah.
phone like that too, and grasping a phone and manipulating it, you get that discomfort on this side of the wrist, right here where the thumb is, where it gets meets up with the wrist. That's a classic spot, and sometimes they can bend down, and you can get a click with it. In fact, I actually myself have had that develop. Obviously, doing surgery and manipulating things and working on things and using my hands a lot and my thumbs, I have to do things. And it started to develop. So I did some stretching techniques and used some local topical creams to help out with the discomfort. And just the therapy exercises that I was doing was able to help to resolve that. And then an occasional Motrin was helpful as well with that, or ibuprofen, I should say.
Are there protocols in the PT in the Genie Health app um, that can like a prehab, can kind of help solve those? Are you using
Oh,
those yet? I don't know if those exist yet.
yeah, absolutely. We have a lot of different therapy protocols, prehab or otherwise. I mean, I would say it's not really a prehab; it's more of a treatment.
Yeah.
Um,
Right.
so prehab being more like before surgery,
Right. Right.
like to optimize a patient prior to surgery. But I would say this is more of a treatment actual plan for wrist and hand conditions. And yeah, absolutely, we have that. And if there's something, the beauty of PT Genie and the Genie Health app is that if we do not have it and it's something that we wish to develop, we develop it, and we take the feedback from our patients, and we'll make it happen. So there's no area that we can't make that happen with that, because the platform is what we're using,
Right.
is the assisted virtual therapy and these videos, and our therapists like Sarah are fantastic, and they can really
Yeah.
help out and development of things. So
No, that's a beautiful care model you have there. It's great. It's wonderful.
mhm,
With the in office and on your phone home exercise program, it's a wonderful thing. Patients do love it.
mhm.
Were there any other questions that anyone had in the chat? I don't see any other. I mean, this was very informative, Dr.
Oh, it looks
Callahan.
like I got some. I'm able to pull it up now.
Oh, I don't see
Um,
any. Okay.
Yeah, so in the meeting chat, it looks like there's some questions here. I'll try to answer them. And again, I'll say that any specific questions before I can pull this up here, just while I'm waiting for here this to pull up, is that any specific questions I can answer in office. So just another highlight, just for privacy purposes and for appropriate evaluations, I can answer any of those in office. So if you schedule an appointment, I'm happy to do that. So let's see. So let's see. One question I have on here. Why does tennis elbow keep recurring? How do you solve it? Well, tennis elbow, that's a very challenging thing as far as repetitive motions of the hand and wrist and elbow. Um, it's an area we didn't specifically talk about today. That's more of an elbow problem than a hand or wrist issue. But because I'm happy to answer that question right now, is that it's tendonitis. Really, it's a tendinopathy of the elbow. Those tendons that help you bend your fingers backward, they start up at the forearm, and they start up at really come off of the humerus bone, which is your arm bone, and on the outside part of your elbow, that area is get that tendon becomes um, diseased, and rather than being a true tendonitis where there's inflammation of the tendon, it's a tendinopathy, and what happens is that tendon gets degenerated, and it makes it difficult because the tendon degeneration is different than inflammation. It forms abnormal tissue, and so we try injections into that with steroid to help relieve some of the discomfort. And the thought is that if we can relieve the discomfort, and you'll be able to kind of adapt your motions and your activities. And with some physical therapy, maybe the diseased tendon can help to heal itself. There are other injections you can do, like platelet-rich plasma, that can maybe help to stimulate that. There's dry needling techniques, physical therapy, exercises, surgical debridement, where you actually cut out the diseased tendon and plus or minus the repair of that type of condition. There are several techniques to address tennis elbow. I can think of at least 6 different techniques off the top of my head as far as surgically how you address tennis elbow. And so, if you could tell, um, most conditions, they don't require 6 or 7 different techniques to address them. So if you have 6 or 7 techniques, it means one of them is not one of them is that great to address it. So it can be a very frustrating condition, to say the least, and it can recur. So because tendons can get diseased again as they heal, they can be, if you formed it once, you can form it again, or it could be more extension into other parts of the disease, as far as like another tendon, or it could be that there is pain from there's a ligament that's on the side of the elbow. Maybe that's being irritated. So there's a lot of different reasons for that. So that's kind of a long answer, and it might not have totally answered your question. But the idea is that tennis elbow can be really nagging and frustrating. It's frustrating for surgeons. I can say that personally, but then also for patients. So I can understand why that could potentially bother you. But yeah, I guess maybe for further discussion, we could have a personal consultation about your specific circumstances. Next, is trigger finger surgery done endoscopic or an incision? It's a small incision. It's a really like a centimeter at most. So about that big at the base of which specific finger is involved. It's a small open incision, and again done outpatient under local. Um, the What's the side effect? What side effects evolve from steroid shots? What about stem cells? Can that be a solution? So great question. Side effects from steroid injections. There can be some local reactions, some redness, pain from the injection site. So people who have darker skin, it can cause, if it gets into the skin layer, it can cause some hypopigmentation, meaning that the skin becomes lighter at that area. The specific tendon can have it can fail to work. There can, again, that pain that persists after that, and then let's see what side effects evolve from steroid shots. What about stem cells? So stem cells are something we're learning and growing more and more over time to address the utility of that. And it's a growing area. We know in joints, as far as like cartilage restoration, that's showing more promise with that. As far as tendinopathies or tendon conditions, the stem cell injections, we're still learning where they're the most useful. I think platelet-rich plasma has certainly shown a lot more evidence to support for that. We could certainly talk about that in a consultation office, though, if you want more information about that. But I'd say probably platelet-rich plasma has been shown to be a little bit more effective for tendonitis type conditions. Next question. Can you explain ulnar nerve surgery? So ulnar nerve surgery is a different nerve. We didn't talk specifically about that compression, but it can happen at the wrist, that same area of the hand, very near the carpal tunnel, where the ulnar nerve lives, and that a little bit more rarely can be involved and cause a compression of the nerve there, and that can give some symptoms into the small finger or the little finger of the hand, and a little bit on the outside part of the ring finger, numbness and tingling and discomfort through there. It's more common the ulnar nerve is compressed at the elbow. And that is a condition that's called cubital tunnel syndrome. and that causes that compression there. And sometimes that's requires a surgical release, and that would usually be an open incision over the elbow, and release the soft tissue bands that are compressing the nerve through the elbow. Um, are there certain fingers that are more prone to stick and become a trigger finger? Yeah, I'd say more commonly the long finger and the ring finger are the two most common that I see and that are seen for trigger finger. But they can occur in any of the fingers, and the thumb even particularly can get it as well. And so people will sometimes describe pain in their thumb. They think it's arthritis, it's clicking or popping, and the next thing you know, I'm examining them, they have a trigger thumb. And so it's the same type of, or it's the exact same condition. It's just a different digit that's involved. Let's see. Second question on elbow: does improved muscular strength improve tennis elbow, or better stated, reduce the incidence of it? That's a great question. We know physical therapy helps with elbow conditions in general, and can help with tennis elbow. As far as preventing that, that's less clear. But certainly, we know that doing the exercises helps to resolve it for patients, or support it while it's recovering and healing. So I think that in my mind, having good flexibility and strength through any part of your body is going to be superior to having a less strong part of that body. Can physical therapy address trigger finger? These are great questions, by the way. So thank you for sending them in and asking these questions. They're right on point with a lot of things, even if it's not the topics we discussed. You guys are asking great questions. Can physical therapy address a trigger finger? It can help trigger fingers. It probably helps more once if you have an active trigger finger. Pushing the digit through physical therapy alone will probably be more painful and difficult to actually do. But I think in combination with either anti-inflammatories, or particularly an injection, a steroid injection, I think that certainly can help a lot of patients. And so I'm hard pressed to say no to physical therapy. I think it's a great thing. And after the surgical procedure can be helpful as well, prevent scar tissue forming, those types of things. So yeah, absolutely. Let's see. Um, do I do video office visits? Yes, I do some video office visits, or like telehealth visits. I will do those. It depends on the circumstances. Particularly, obviously I can't inject you from a video, but I can do consultations through video. And then if there's something that we need more involved, we certainly can do that. But yeah, if you call our office, we can set up a virtual appointment whenever it's convenient. Let's see. I have a pinky and ring finger pain extending to my wrist. Does a cortisone shot in therapy, or did a cortisone shot in therapy? Any suggestions? I'm presuming that didn't work for you. Still having, oh yeah, still golfing and still having pain. Um, yeah, so again, it's hard to say specifically because this is another one of those that's probably best to see in office and to evaluate, without having the specifics about your circumstance and being able to look at you and examine you. We could probably do a better job of giving you answers, but about that, generally speaking, over the counter pain relievers and cortisone injections and therapy are very effective. But if there's still pain there, it could be the condition is just not improving and it needs evaluation further, or sometimes that's a sign that you're going towards needing a surgical procedure. But again, I won't say that specifically your case, as I don't know the specifics. So we'd have to happy to see you in office. Yeah, we talked about video office visits.
Yeah, and I'm not sure, but I think at one we might get cut off. I'm
Oh,
not
okay.
sure.
Yeah, I think we're gonna have to wrap it up here. So that was probably the most questions I think I've fielded in a while. I mean, that's a great questions. Thank you for participating. I think we'll have to just wrap it up here. I'm happy to answer your questions in consultation, especially specific questions. or issues you've been having, we can do that. You just can call our number there. Kelly, do you have anything else?
No, I'll email a link to this live recording. I'll post it on YouTube, and the Cleveland Shoulder website because it's shoulder related. It'll be on the Cleveland Shoulder website and emailed to you in your inboxes. So you'll have it by the end of the week.
Great. Well, thank you so much, Kelly. And thank you to everybody
Sure.
who was involved in the webinar today. I hope you have a wonderful rest of your day, and look forward to seeing you out and about. Hopefully, as this weather starts improving, we can see you out and out and about town or something instead of just in the office. But again, if there's anything I can do for you, I'm happy to see you in a consultation. And again, hope you have a wonderful day. Thanks for coming.